There is absolutely nothing going on with me romantically.
Great. Can I buy you a drink?
Alrighty. How's everybody doing today? Yeah, being here on a holiday is always hard, so I appreciate y'all being here. For sure, for sure. I'm just checking who all is here. Yeah, we have at least one person on Zoom. Looks like just one for now, but more might roll in on Zoom. So today I have just a couple things I'm gonna touch on from last time that I didn't quite get to. And then we will talk about neuroanatomy to kind of get us all on the same page before on Wednesday, we're going to dive into our first set of disorders. So on Wednesday, be sure you bring or have accessible via whatever electronic device your case study book, because we'll be working through a case study. Alrighty, so the one thing I didn't get a chance to talk about last Wednesday is the problems with neuropsychological assessment. Not everything is always sunshine and roses, right? And how much the assessment helps depends on a lot of things, whether you're using the tests that are actually right to answer the question you're asking. If you yourself as a neuropsychologist are actually trained and skilled in giving these assessments. And then what's going on with the person that day? Are they having like the best day ever? Or are they just like feeling really crummy and that's affecting it? Patients can malinger or be uncooperative, and kids can be especially hard. So there were 5 of us on residency together in Augusta, Georgia. 4 women, we were all about the same height, and then Brandon, who was 6'2". And Brandon was our child person, and he was doing some neuropsych testing on a kid, and the kid took his chair and wedged it against the door and was like, I'm not gonna do this and you can't go anywhere. And Brandon, being Brandon, just went over and picked up the chair and moved the kid and went to get his supervisor in the kid's box. It's not normal for when you're doing a neuropsych assessment, right? But the type of thing you can run into. Issues can arise with diversity. Normative tests aren't necessarily available for every population. They're typically designed in Caucasian Western males, cisgender, straight, all that fun stuff. And sometimes they're not normed in other people at all. So when I took this class as an undergrad, my professor, Professor McFarland, said, even in research, we use males most of the time because they're simpler. Women have these pesky hormones, which is funny because men also have hormones, right? Like anyone who's a human has hormones. So this is not only an issue in neuropsych in general, but also in healthcare as a whole. So for example, heart disease is a leading killer of both men and women, but we think of it as being more of an issue in men, and we're actually taught to recognize the symptoms of heart attack in men, but they're different in women. So for women, they're much more likely to feel nauseous and have more pain up through their shoulder rather than down their arm. So when women have a heart attack, it might get diagnosed as something else. They might not bother going to the doctor because recent research has shown that the pain of menstrual cramps for people with a uterus is as intense as a heart attack. So if you're used to having pain that intense, right? You might not be like, well, this just feels like normal. It's just maybe I have heartburn this time, right? When they developed heart medicine medication and some of the medication we use for neuropsychological things, it was often developed on men, and it doesn't always act in the same way of people who of marginalized genders. And so we need to have our eyes and ears open at all times as neuropsychologists and make sure we're not ruling things out. So we also need to be aware that we're not overdiagnosing people as having a neuropsychological problem when it's just a language or a cultural barrier, which can happen. So for an example, there was a medical resident, so someone obviously very well intelligent from India and the US. And a patient told this resident, oh, I have butterflies in my stomach. And this resident from India was like, my patient is delusional. They're thinking there are animals in their stomach. They didn't know that that was like a colloquialism here, right? And so we can have these cultural misunderstandings. So that was a part I wanted to make sure that I covered. And then today I do have some slides that we can kind of follow along with. And the first thing on your SGA that we looked at was this little story from the start of the chapter about RS. So how can stroke affect the brain? And we'll talk about stroke a lot more later in the semester, but what do y'all think? Yeah, and depending on what type, it might cause lesions, it might cause bleeds into the brain.
Is there a problem with blockage of blood flow or burst the blood flow, which prevents the writing of the blood to the brain? It's the area.
Right, yeah. So a stroke is the equivalent of a heart attack, but in the brain, basically. So yeah, you can either have blockage and or exploded artery, not good, right? Blood into the brain when it's not supposed to be there. And it depends on where the stroke is, how your functioning is affected, right? If it is back here, your vision might be affected. If it's up here, your ability to organize might be affected. So RS felt numbness in their left hand and then collapsed and fell to the ground from the garage roof. Not great. They also had a fall, right? They had right frontal cortex damage. So this is the brain, as if you're looking from like the top of my head. So this is where the eyes would be. This is the back of the brain. So right in through here, you can see the blood that went into the brain. Not great. You don't want something that's not supposed to be there to be there. Their left arm went rigid and they didn't really make an attempt to use it. They had difficulty in their motor functioning, but learned to walk again with rehab. Then they could do activities, but they were really apathetic. So the stroke really led to changes in their behavior and their personality and their motivation. And so stroke itself, again, as I mentioned, we'll talk about this more later in the semester, but stroke is an interruption of blood flow to the brain. So y'all hit it right on there. And An ischemia in particular is a deficiency of blood flow to the brain, from a blockage most likely. And then a hemorrhagic stroke is a burst of a blood vessel. So in RS, we had the right frontal cortex, including the precentral gyrus, which affects motor ability. Strokes, as you can see here, are really common. The third leading cause of death in the US, although that may have shifted because unfortunately now COVID is up near the top. And it's a leading cause of long-term disability, and it can happen at any age. So there are cases of folks your age or even kids having strokes. Alrighty, so for the next piece of this, I thought I'd do something a little more fun. And so I'm gonna give each of you a post-it note, and it's got a term on it. And even if you didn't do the STA, you can figure the term on something as it relates to the parade. And rather than me just reading all the definitions for you, y'all are going to say them for me. Sorry. And I've got some of them since not everybody's here today. So I'll give you a minute or two to look those up, and then I'll have y'all define them for us. Oh, no. I accidentally closed my Chrome window. Alrighty, people feel good, people feel ready, everybody found yours, cool. All right, I think I'm gonna put this in slideshow mode just so we could see it a little more clearly. So these terms are gonna give us ideas about the locations of things in the brain with respect to other parts of the brain or other body parts, with respect to their relative locations, and with respect to viewer perspective. So I did like that they kind of gave you the breakdown here of relative to the body parts, relative to location, and relative to the viewer. So I have the first couple here. So and let me see, I think we had a prettier diagram too. Yeah, cool. This will get us some of it. All right. So a rostral means beak, or basically kind of like front. And this again is a relative to other body parts. And the caudal is like the tail end. And then someone else had dorsal. I'm gonna turn that off so I can hear everybody. Go ahead. Exactly. Yeah. So up towards the top. A nice way to think of this is if you're familiar with like fish or dolphins, their dorsal fin, right, is right here. So that's a nice, easy way to remember. Okay, dorsal is towards the top. All right, ventral. Who had ventral? Anybody? Okay, go ahead, Mara. Yeah, basically, it's kind of like the opposite. So if we're looking this way and dorsal's up here, then ventral would be down here. Again, if we're looking at a dolphin, ventral would be more tummy. Exactly right. Okie dokie. How about anterior / frontal? Right. Some of these are pretty simple, right? And you can see here, right? Anterior. Okay. And then posterior. Yeah, the back. I know we talk about posteriors and derrieres, right? Colloquialisms. I had lateral, so lateral is the side. Again, a nice way to remember this is your lats, right? Your muscle groups that are on the side. All right, who has medial? Exactly. So this arrow isn't the most helpful, but it's supposed to be pointing like into the middle. Some of these are hard to tell. All right, how about ipsilateral? Exactly. Yeah. So some structures will be on the same side of the brain or the body. All right, contralateral. Exactly. On the opposite sides. Yeah. All right, bilateral. Exactly. So in the brain in particular, this would be one in each hemisphere. Most structures of the brain are bilateral. There are a couple notable exceptions we'll talk about. Proximal.
Structures that are located close together.
Exactly. So if we go back to the slide, proximal would be one that's like relative to other body parts. It's not actually listed here, but and then distal. Exactly. And then I had afferent and efferent. So afferent is AFFERENT, is movement toward a brain structure. So that's your sensory pathways in your nervous system. If you remember old like Schoolhouse Rocks or things like that about how your senses send messages to your brain. And then efferent, EFFERENT. That means away from the brain, and those are your motor pathways. So we have that the brain is generally organized symmetrically. And here's the efferent and the afferent. Just so you get kind of a vibe for that. All right, so now we're going to start talking about the various nervous system structures and functions. Again, we're not going to get totally into the nitty-gritty of everything, but as we talk about each disorder throughout the semester, we'll talk about the brain structures related to that disorder. So the central nervous system is what we think of when we think of the nervous system. It is the brain and the spinal cord. The somatic nervous system is all the spinal and cranial nerves to and from the sensory organs and muscles, the joints, the skin, all that good stuff. And the somatic nervous system produces movement and transmit that incoming sensory information. And often it's disturbances in this system, the somatic nervous system, that are most noticeable when there's some sort of neurological problem taking place. And then we have the autonomic nervous system, and this is the one that does stuff without us needing to consciously tell it to. This balances the body's internal organs through the sympathetic and parasympathetic nerves. So the sympathetic are what speeds things up, the parasympathetic are what slows things down. And so here you can kind of see how those break down. I actually, looking at it, don't know how helpful this diagram actually is in the grand scheme of things. That's all right. Thanks for trying. Okay. Yes, well, actually, a lot of different systems, depending on physical things, can be affected. But yeah, the nervous system could sort of rewire itself after trauma, for sure. And people will take on safety behaviors or things along those lines. Yeah, for sure. So how is the brain and the nervous system protected? So the first thing we think of is the bones. So we have the skull, right? And then we have the spinal cord around our, the vertebrae around the spinal cord. And so those are our biggest protection. And then there are the meninges. And these are layers of membranes, basically inside the skull and the vertebrae, between that and the actual brain structures. So the dura mater is the outer. It's a tough double layer of tissue. It basically puts the brain in like a Ziploc bag. Weird analogy, but it's like a tough sack. And then the arachnoid membrane is the middle. It's very thin and it follows the brain's contours. So it'd be like if you shrink wrapped something. Sorry, I don't know why I'm thinking of like things in my drawer that I'd wrap food in, but that's where my brain is right now. And then you have the pia mater, which is tissue that clings to the brain surface. And then cerebral spinal fluid, which is throughout our brain and our spine, and it cushions things. So this gives you a nice diagram of here's the skull, the dura mater, the arachnoid membrane, and we'll have a case later in the semester where someone specifically has a problem right here. The pia mater, then there's this subarachnoid space, and that's just filled with cerebral spinal fluid. So one of the best analogies I've heard for the brain, especially when it comes to like traumatic brain injury, is it's like the brain is jello floating around in liquid inside these other sacs. Right? So if you smack something on the outside, the brain's gonna slosh around there. And it's cushioned a little, but it's still gonna probably bang into stuff. And it's jello, so it's gonna kind of react in different ways. And the CSF also goes through the ventricles in the brain, which I'll show you in a minute. And then the blood-brain barrier also tries to help to limit things from coming into the central nervous system from the other side of the body. So there are many viruses and bacteria, for example, that the blood-brain barrier prevents from attacking the brain. However, there are things that can pass over it. Unfortunately, like COVID can pass over the blood-brain barrier. If you get too much cerebral spinal fluid, you can develop a condition called hydrocephalus. And this, I don't think I have a slide about. Yep, I do. Okay, there we go. So sorry if people are disturbed by photos like this. So I'll kind of like flip by. But basically, hydrocephalus is water on the brain. If the outflow of cerebral spinal fluid is blocked, then you can have what that baby had where your brain kind of swells up because of this extra fluid. It can result in severe developmental delay and or death. It's a relatively common finding, about 1 in 1,000 in the US for stillbirth, newborn, and early infancy. And it can be genetic, or it can be acquired, often due to injury during the birthing process. These infants tend to be irritable, they won't feed, they won't gain weight, which won't be as obvious because the head will weigh so much from the retained fluid that it'll look like they're gaining weight appropriately. The head circumference being more than 2 standard deviations above the mean and deserves investigation. You'll see something called the setting sun sign, which is the retraction of the upper eyelid without an up gaze. So the iris seems to set below the lower lid. Kids who get this later will have headaches, vomiting. They'll have failure making progress in schools. They can develop seizures, migraines, things along those lines. There can be motor problems. Adults who develop this have unremitting headaches. Sometimes they'll get really bad cold symptoms that won't go away. Nausea, vomiting. And then if you get it late in life, it's associated with dementia. These folks, in terms of neuropsych findings, in infants and small children, we see just a general delay in motor deficits. In children who are a little older, we see that their full-scale IQ looks normal. But then their visual IQ will be better than their verbal IQ will be better than their performance IQ. So they can do word stuff better than non-verbal, word related stuff. You can shunt them, which means you put a tube in there to drain it. And those kids do a lot better. They can often be in mainstream classrooms instead of within special ed or a special school. They will have some gait and motor abnormalities. And adults, you'll just see progressive deterioration, unfortunately. You can diagnose this prenatally via ultrasound, and then the parents may decide to terminate pregnancy depending on the predicted outcome. In adults, you would use a CT or an MRI. And again, the shunt is the most common treatment. Hello, projector. Okay. My screen was still on up here. Don't know what happened. What's that? Oh, gotcha. Cool. I'm just like, I'm a ninja. Not really. Okay. And you can do compressive head wrapping. There are medications you can take. Sometimes they'll do a lumbar puncture to remove the excess cerebral spinal fluid. And you need to make sure you rule out other things like it's not just that they have some other metabolic disease or increased cranial pressure because of a tumor or something along those lines. So you need to be cautious as you go through these things and make sure you're diagnosing appropriately. All right. So I mentioned the blood-brain barrier. The blood supply is very important to the brain. If your blood supply is disrupted, then the flow of oxygen to the brain is disrupted, which means the healthy function of the brain is disrupted. And so even people who have like momentary blockage, so for example, people with sleep apnea, where they stop breathing for a sec, so their blood's not as oxygenated. Over the long term, that can actually lead to some cognitive issues. So you can see there's multiple arteries that come up here. So there are a lot of places that it can go there, and then it does return to the heart through the veins like any other part of the body. And here you can see where those arteries work their way through the brain. So again, if they're going to have a stroke, these are the places that are going to be affected first. Alrighty. So there are different types of cells in the brain. We think of just neurons, Okay, that's what I have on my dress today. But there are neuron stem cells that are undifferentiated, that they can self-renew. There are progenitor cells that can migrate and act as precursor cells, and then blasts develop into neurons in glia, and they cannot divide. And so glial cells are the helper cells of the brain. So glial cells are going to do things like clean up junk in the brain, provide support to the neurons, things along those lines. All right, so then we have different types of neurons. We have sensory neurons. They're just what they sound like. They bring information from the central nervous system, to the central nervous system from the body. The bipolar neurons are a cell body with a dendrite on one side and an axon on the other. And then the somatosensory neurons are where the dendrite and the axon are connected to speed up connection. You're not going through the cell body. And these come from your sensory receptors all over your body, including your eyes, your ears, all that lovely stuff, into the spinal cord and into the brain. The interneurons link your sensory and your motor neurons. They have a lot of dendritic branches and then one axon typically. And then motor neurons, not surprisingly, go to your muscles and they tell things what to do. And so the brainstem, which is the part of your brain right here on top of the spinal cord, this is where a lot of your most basic functions happen, that goes to your facial muscles, and then the spinal cord goes through the muscles throughout the rest of your body. And so here you can see what the various types of neurons might look like. And I think on my dress, they tried to portray those, but they just made them really artsy. So they look more like flowers. All right, and then these are the different types of glial cells. Again, those helper cells that aren't neurons themselves, but help throughout the brain. So the ependymal cell, secretes cerebrospinal fluid. Important, right? We just talked about how important that fluid is. Astrocytes help with nutrition and support. Microglials are defensive, so they're going to help in immune functioning and against the gunk building up in the brain. Oligodendroglial cells form around the insulating, form the myelin around the axons in the brain and the spinal cord. So the myelin sheath, if you don't remember, I think we mentioned this the other day, that is your wrap around your electrical cord. It makes things more efficient. It makes it so electricity is not just spurting off of things, right? And in certain brain disorders, that myelin breaks down, which is problematic. And then Schwann cells also help to create myelin, and in particular, they do it in the peripheral nerves. Alrighty. Gray matter gets its color from the fact that your capillary blood vessels and your neuronal cell bodies are in this part of your brain. And it's made up of the neuronal cell bodies. The cell bodies are sort of the blobby parts on my dress here. And so they are bigger, and that's going to affect the coloration for that reason. The gray matter includes regions of the brain involved in muscle control, sensory perception, such as seeing and hearing, memory, emotions, and speech. It's distributed at the surface of the cerebral hemispheres, the cerebral cortex, and also of the cerebellum. And then the white matter, here your color is from those glial cells, that myelin sheath, that insulating layer. White matter is the tissue through which messages pass between different areas of gray matter within the central nervous system. The gray matter can be thought of like as a computer, right? So this is my gray matter. And the white matter are these network cables I almost trip on every time I'm teaching down here, right? That connect it to other computers and to the network itself. The white matter is white because of that myelin that surrounds the nerve fibers. Myelin is found in almost all long nerve fibers, and it allows the messages to pass quickly, as I just said. The brain in general can adapt to white matter damage by finding ways to route around. So that is actually a really good example of flexibility, neuroplasticity. White matter forms the bulk of the deep parts of the brain and the superficial parts of the spinal cord. So things like the basal ganglia, which will come up a lot throughout the semester, the brainstem, those like the substantia nigra, those are all going to be white matter. The cerebellum is structured in a similar manner as the cerebrum, with a superficial mantle of cerebellar cortex. I cannot say that word today. Deep white matter and aggregates of gray matter. And then MS, which we talked about last week, is a disease where the myelin sheath gets destroyed due to inflammation. And so that makes it harder for messages to go along. When the glial cells cannot work as well, particularly the ones that help clean, then we have plaques that develop in the brain. So in particular, in Alzheimer's disease, it's amyloid plaques, it's just a type of gunk, amyloid beta, that builds up in the brain. Other neurodegenerative diseases are similar. And then the reticular matter is sort of modeled between the two colors. And it's from both cell bodies and axons. And so this kind of gives you a little bit of a feel for where those white and gray matters are in the brain. This part right here is the corpus callosum. Does anyone remember maybe from other psych classes what the importance of the corpus callosum is? Yeah, all of it. Exactly. So it is the main connection between your two hemispheres. One of the things that can happen if you have very severe seizures is they try to lateralize them to one side of your brain and they can cut the corpus callosum. And then you have some problems in the two sides of your brain to talk to each other. There is another very small crossover of the optic nerve, but it doesn't have the same capacity, I guess would be the best word. And here you can see where they've stained the gray matter and the white matter. You again can kind of see it in the brains. Alrighty. I am going to skip forward a little bit here to talk about the ventricles. So I mentioned these when we started talking about CSF. These are hollow pockets within the brain that are filled with the central cerebral fluids. And these help with things like balance, the health of the brain, things along those lines. So as you can see, they're kind of throughout the brain here. And these are, actually, hang on just a sec. Go back to one of my brain pictures here and I can show you more clearly. The ventricles are one of the things that is most obviously identified on brain scans. So they're these right here. Typically, if you see anything really dark on a brain scan, it's bad. The ventricles are the exception. The ventricles are supposed to be there. If they are symmetrical and appear to be fluid filled, that is a good sign. All right, so a little bit more here about the spinal cord. And so one of the things I did on my residency for one rotation is I worked in a spinal cord injury unit, which was very enlightening. Because I learned a lot about like how your amount of damage relates to how high up your injury is. And also all the ways people get spinal cord injuries, even in the military. You know, things that perhaps don't surprise you are like parachuting accidents, landing too hard. Things that do surprise you, someone was drinking and biking, not motorcycling, bicycling, and flipped over a fence, and that's how he got his spinal cord injury. So don't drink and do any sort of vehicle, I guess. Probably not the best idea. So the body is divided into these different segments within the spinal column. And based on where along your spinal cord you have your injury will determine how much of your body you are still able to utilize in the way you could pre-injury. If you have a lower spinal cord injury, you might be able to still walk with the aid of a walker or a cane. If you're getting higher and higher, especially into the C range, C3, C4, you might be quadriplegic, which means you wouldn't have the use of any of your 4 limbs. So they're connected by cerebrospinal fluid, by nerve fibers. The vertebrae are there to try to protect it. The cervical segments control the arms. The thoracic segments, the T in through here, control the trunk. The lumbar here, the L's control the legs, and then there's the sacral segments, which are kind of the posterior. We'll use our term here. And so I do have a video about loss of cerebrospinal cord function and injury and rehab. So let me get right back into my Blackboard here for the link.
Hi, I'm Marcy from brainandspinalcord.org. Today I'll be bringing you some information on the levels of function in spinal cord injury. Be sure to check the website for all relevant links and recap of this article. If you or a loved one has sustained a spinal cord injury, you've most likely heard the doctor or medical team classify the injury with a letter or number, such as C4 or T2. What do those letters and numbers mean? These letters and numbers refer to the levels of function a spinal cord injury survivor has after the injury. Before I get into the specific levels of function.
So it is related to the levels of function, but it's also literally related to where physically your injury is. So
I'd like to go over how the human spinal cord works, as well as the impact of spinal cord injuries. The human spinal cord acts as a conduit between the brain and the rest of the body, relaying messages. When the spinal cord is bruised, crushed, or torn, the messages sent between the brain and the body no longer flow through the damaged area of the spinal cord. What does this mean? It means that the functions of the body located above the point of injury will continue to operate normally, while the functions below the point of injury will suffer some degree of impairment, including motor deficit, sensory deficit, bowel and bladder dysfunction, and respiratory difficulties. The letters and numbers that doctors refer to.
One thing that they're not mentioning here that is a problem that does distress quite a few spinal cord injury patients is reproductive function as well, right? If your area of damage is above the part that would control reproductive function, you might have to use a whole host of aids in order to be able to engage in sex.
After a spinal cord injury are used to identify where along the spinal cord the injury occurred. The higher the point of injury, the greater the impairment. C-level injuries occur in the cervical area of the spine. An injury that occurs in the C1 to C3 area results in limited movement of the head and neck only, with paralysis below that region. In many cases, the survivors of C1 to C3 injuries have difficulty talking and require the use of a ventilator to breathe. Survivors with C3 to C4 injuries have head and neck movement, as well as some limited shoulder movement. They're typically able to talk and can eventually adjust to breathing without a ventilator. Those with C5 level injuries generally have head, neck, and shoulder control and can bend the elbows and rotate their hands. At this level, self-care is manageable. Survivors with this level of injury can often push their own wheelchair, and driving is frequently possible with adaptive equipment. A C6 level injury results in movement of the head, neck, shoulders, arms, and wrists, including the ability to bend the elbows, extend the wrist, and rotate the palms. The population who falls into this category is generally able to perform most self-care duties, can perform light housekeeping, and can manage a manual wheelchair. Those with C7 injuries have similar abilities as those with C6 injuries, but can manage more easily. Injuries that occur at the T level of the spinal cord occur in the thoracic region of the spine. If you or a loved one has been diagnosed with a C8 to T1 level injury, in addition to the use of the head, neck, shoulders, arms, and hands, the fingers will also be able to be used. Survivors with injuries in this range are generally able to live independently. Survivors with T2 to T6 have normal function in the upper body, but have some degree of impairment in the legs. Some can walk with assistive devices, and those with T7 to T12 level injuries have similar function with slightly more control. L level injuries occur in the lumbar region of the spine, and survivors generally have some ability to move the hips and knees. With this type of injury, walking is often possible with assistive devices. This concludes our segment on the level of function.
And so not only do you have those physical issues, obviously, but you also have emotional consequences from the loss of those functionings. So thinking about it, what sort of emotional
Lacking
issues?
Potential does not in itself explain how a neuron sends messages. Sending
It's okay. I was like, what? Huh? Siri, is that? So what do you all think would be some of the social-emotional consequences? Yeah. Depression is a huge one. Yeah, I mean, some of these people were chipper and great, but they were people who had been with their injury for years and had adapted. What are other things? Anxiety, right? Especially if you're not able to care for yourself and you always were. Kind of hand in hand with that, depending on how you got your injury, it might be PTSD as well, right? And depending on, like, if you get your injury from a fall, you might also have a traumatic brain injury, which is going to affect things. So lots of things going on. In general, the folks, and again, as I mentioned, who had it for a while, coped okay. I had a guy who was younger than probably most of you are. He was like 17 to 18 and had gotten it during basic training. Fell off the climbing wall and he had an injury. He had a really hard time adjusting because he expected his whole life to be in front of him without any sort of disability, right? And so that adaptation can be really tricky. Yeah, one of the main things that my supervisor, Dr. Moberly, dealt with was actually the reproductive stuff. None of the doctors would mention or talk to them about sex because I think there's this horrible inaccurate idea that people who have disabilities are not even interested in engaging in sex. So she talked to them about penis pumps and shots and all that good stuff. She's like, never thought this would be part of my job, but it is now. She could see some of the spinal nerve connections and how intricate it is here. And this is a cross section of the spinal cord where you see some of the sensory stuff. You see how the vertebrae wraps around trying to protect it. But obviously, if any of your discs not only get injured, but bulge or all the lovely things that can happen to you as you get older or due to injury, that can throw things off as well. One of the things your book mentions is the Bell-Majendi law. Sure, why not? And so these are the two researchers, and they came up with the principle that the dorsal, your back part of the spine, is where we have your sensory nerves, and then the front part of the spine, your ventral part, is your motor. And I mentioned the paraplegic versus quadriplegic. But as you saw, I think the video does a much better job of describing sort of the range of functioning people can have. I'm just kind of skipping ahead here. Some of this stuff we'll skip over. This kind of shows you the autonomic nervous system in greater detail. So you can see where things connect for the lungs and the heart and the stomach, and again, all the things that we don't have to consciously sit there and go digest, stomach, digest, right? But again, you can also see, you know, if you have a cerebral injury, then you need to be worried about are your autonomic functions. Normally they're okay, but as you heard, like those upper cervical injuries, sometimes they have to be on a ventilator, right? Because it just won't do it automatically anymore. And then the parasympathetic nervous system, as I mentioned, helps calm the body down, rest and digest. This one is I forgot to mention the fight or flight part of it. So we need a system that like helps us calm back down once we're in fight or flight mode. All right. Okay, so now we're going to start talking about the brain itself. And the brainstem, as I mentioned, is super important because it does a lot of these innate autonomous functions. It produces more complex movements than does the spinal cord. It's responsible for sensory and motor functions. And it regulates cardiac and respiratory function. It also regulates the whole central nervous system. And it maintains consciousness and regulates the sleep cycle. Pretty important, right? And there are various parts here. So we have, and again, brainstem right down here at the bottom of the brain, right on top of your spinal cord. So we've got the hindbrain, the midbrain, the diencephalon, and the cerebellum. So the cerebellum, the surface is gathered into folia, these narrow folds, and it coordinates and helps learn skilled movements. If you have damage in the cerebellum, it means that you'll have problems with equilibrium, postural issues, and impairments of skilled motor activity. Trying to show you. Yeah, let me move my captions here. Okay, so the reticular formation is here, sort of inside the brainstem, and that maintains general arousal and controls sleeping and waking. The pons is this part here, and then the medulla is the part underneath it. These serve many functions, including, hey, look, that's like exactly what's on here. Waking, sleeping, and walking, basically, because that's what locomotion is. All right, so then we're going to talk about the midbrain. The tectum is located dorsally. It's the roof. It gets sensory input from the eyes and ears. And the tegmentum is located ventrally. It's considered the floor. It gets input from the eyes and ears as well. The red nucleus focuses on limb movements. The substantia nigra are focused both on reward of behavior and initiating movement. So anytime you start to move, your substantia nigra is part of that. And then you have some gray matter back here that really focus on species typical behaviors. So these might vary from animal to animal. And it's going to connect information between the forebrain and the just blanked out. The other parts of the brain. Geez. Okay. So here again, you can see some of those parts. This is like a cross section. So the substantia nigra, the red nucleus, the reticular formations. There's that gray matter. The cerebral aqueduct is what the cerebral spinal fluid chills in. And then the superior colliculus. All right, then you have the diencephalon. And this is where you're going to hear parts of the brain that are probably going to be more familiar to you. So you've got the hypothalamus, 0.3% of the brain weight, but it does some pretty important things. So it interacts with the pituitary, and it participates in nearly all aspects of motivated behavior. So eating, sex, sleeping, temperature regulation, emotion, movement, and our endocrine function as well. The epithalamus is the posterior of the diencephalon, and it's linked to our biorhythms, hunger, thirst, the pineal gland. And then the thalamus relays sensory information to appropriate targets, relays information between different cortical areas in the brain, and relays information between the rest of the brain and the brainstem. So it's a big connector, basically. And this shows you the breakdown of the thalamus and the various parts of where it connects in the brain by these little colors. So like this, the basal ganglia connect to this part of the brain. Then you have the forebrain, and it has three main structures. The first is the first two, sorry, are subcortical. These are the basal ganglia and the limbic system. And then you also have the cerebral cortex, which is sort of the larger part of the brain. And so the basal ganglia are something, like I mentioned earlier, you'll hear me say a lot throughout the semester. They're tied to a lot of things. And they're associated with movement and learning. And so it's actually related to a whole host of different disorders. So for example, Huntington's disease is sometimes called Huntington's chorea. It's a genetic disorder that has too much cell death. So we all have programmed cell death within our brains and actually throughout the rest of our body. But when that process goes overboard, it causes problems. And the reason Huntington's is sometimes called Huntington's chorea is chorea translates to dance-like movements. And so they will have motions they can't control that are sort of sinuous in nature, and their limbs as well. Parkinson's, where we've got the connection basically from the substantia nigra to the basal ganglia dies off. They have rhythmical resting tremors in parts of their body, like their hand and leg. So what this means is if they're just standing there, they might have the tremor. But then let's say they reach for the remote, they might be okay until they put it down and then they tremor again. As the disease progresses, it becomes more consistent. But for example, there is a gentleman at my church with Parkinson's, and at least until a couple years ago, he was still able to play the guitar. They can have rigidity of movement. It's called cogwheel rigidity, where they kind of move through things in a jerky manner. And this can make it really difficult for them to balance. Tourette's is another connected here, where you have involuntarily motor tics, especially of the face and head. So they can be vocal as well. And involuntary vocalizations. So diseases here in the basal ganglia are problems controlling movement rather than producing movement. So these people can produce movement, but then they have a hard time regulating it. And again, here you can see how the basal ganglia connect to everything else in the brain and what the structure looks like. Kind of looks like old-fashioned headphones to me. All right, the limbic system is really important in the brain because it's related to so many functions like emotion and memory, but the name is sort of a misnomer because it was named for the connections between the olfactory system and the limbic lobe, but subsequent experiments don't show that that's actually like a connection that it has. So, woohoo! Okay, so the amygdala is emotion and species typical behaviors. The hippocampus has to do with memory and navigating through space. And then the septum is emotion and species typical behavior. And so it is linked to emotion, by playing roles in emotional, sexual, memory, motivation, reward, and navigation. So it really contributes to a lot of what we do as humans. All right, just again, skipping forward a little bit here. All right, so fissures are the cleft in the cortex that's deep enough to indent the ventricles, so the little valleys, essentially. Sulci are the shallower cleft, and then gyri are the ridge. And these can be different throughout different people. Alrighty. So now we have the perhaps most important parts of the areas of the brain. I don't know if that's true now that I say that, but the ones that we know the most about when we're first learning about the brain, I would say, the lobes of the brain. When we see a picture of the brain, this is typically what's pictured more than anything else, because a lot of the stuff we just talked about is interior to the brain. All right, so you've got frontal lobe, parietal lobes, temporal lobes, and occipital lobe. The frontal lobe does motor functions, executive control, attention, planning, sequencing, judgment, and social behavior. The parietal lobe does your bodily senses. So sensation, that objectively something is hot. Perception is your subjective psychological experience. So this is hot, but also painful because it's hot. It integrates that information. It helps us with complex attention and storing information briefly. And awareness allows us to self-monitor. The temporal lobe does auditory functions, memory, speech comprehension, creating new memory, and input and output language. And then the occipital lobe are your visual functions. And so this gives you a brief idea of what goes where. And then this talks briefly about the primary versus secondary versus tertiary. Basically, the primary cortexes in each area are areas that receive projections from structures outside the cortex or send projections out of it. The secondary areas are adjacent and they get input from the primary areas and they interpret sensory input or they organize your movement. And then the tertiary or association cortex areas, basically they're between secondary areas and they help connect the different lobes of the brain so that we can do really complex tasks. Alrighty, skipping forward a little bit here. All right. So the brain does have some contralateral organization, which means, so if I see something on my left side, it's interpreted by the right side of my brain. And there are crossing of sensory fibers along the center of the nervous system. So I have a couple more videos, one of which you hopefully will find fun. So this is one of my graduate professors. He actually was on my dissertation committee. And so he was part of our faculty band, which was called Wire Mother. Yes, in honor of the Harlow monkey experiments. And he played the guitar, so he wrote this song and would perform it for his intro classes.
Now, mind you guys, I have no professional vocal training. But go for it. All right, here it is. 1, 2, 3, up. Love really don't mess around, but turning all these parts and make my neurons burn. So I wrote this song, and though it might be wrong,
So just something a little fun. I've got one more video for today. And this is just one specifically on the anatomy of the cerebral cortex. Again, just to sort of renew everything we just reviewed. Everything we
Think
just looked
hairspray
at.
stuck in one
There we go.
dimension? Think again. Flex any style. With hairspray that flexes with you. New Tresemme hairspray.
If we cut a sagittal section, meaning cutting the brain in half along the longitudinal fissure, and look at the frontal lobe from a medial view, we can also see another sulcus called the cingulate sulcus, as well as the anterior paracentral lobule, which forms the medial aspect of the precentral gyrus, and the posterior paracentral lobule, which forms the medial aspect of the postcentral gyrus, which we'll mention later. By understanding the different anatomical landmarks of the lobes, we can start to identify the different functionally specialized regions of the cerebral cortex. For example, the regions of our cortex that are responsible for controlling motor or sensory functions that assist with our everyday lives. When considering the functional areas of the frontal lobe, it contains the primary motor cortex, or Brodmann's area 4, that occupies the area of the precentral gyrus and extends over to the medial aspect of the hemisphere as the anterior paracentral lobule.
Sign up for a free trial today and watch the
This
full
gives
video.
you a little bit of a hint of like how complex our brain is and how much each lobe does. So yeah, I actually wrapped us up a few minutes early today, so I will send you all off. Again, please remember to either physically bring or have access to your case study book for Wednesday, because we're going to work our way through our first case study. You can recycle the Post-its.